السلام عليكم، مرحبا طلاب. شلونكم؟ يعني يا رب تكونون بخير. Our lecture today will be about the treatment of male infertility. Actually يعني this is a very specialized lecture for you. I mean the special topic I would say. يعني حقيقة خاصة، يعني المعلومات اللي بهذا الموضوع تحتاجوها. يعني جماعة الانفرتيلتي اللي يشتغلون بالانفرتيلتي يحتاجون يكونون oriented أكثر على هاي أو this is their specialty. فحاول قدر الإمكان أنه فقط أعطيكم يعني summary of the available medications that can be used to treat male infertility. وكلكم تعرفون الأندروجينز، وكلكم سامعين يعني الأندروجينز، التستوستيرون اللي هو the most important one in human. راح تشوفون انه هو السكريشن مالته راح يتم عن طريق التستس by Leydig cells, or the secretion of testosterone is regulated by gonadotropin releasing hormone from the hypothalamus اللي stimulated pituitary to secrete LH and FSH. The most important one out of all the hormones هو التستوستيرون اللي هو produced by small amount by the ovaries as well and by the adrenal gland in both sexes. Other testosterones or other androgens, that are produced by the testes include the 5-alpha dihydrotestosterone, androstenedione, and dihydroepiandrosterone, which are produced in small amounts. يعني هذا الدياجرام simply show us how the gonadotropin releasing hormone releasing hormones are produced by the hypothalamus to regulate the production of LH and FSH by the anterior pituitary and mainly LH in males, which is responsible for stimulating the testes to produce testosterone or dihydrotestosterone. And definitely these hormones exert a negative feedback mechanism to control the production of gonadotropins. As you know, the androgens are responsible for the normal maturation in the male. Also, they are responsible for sperm production, for an increased synthesis of muscle proteins and hemoglobin. They also decrease bone resorption. So it's as a hormone, it's really important for the males to be to sustain the secondary sexual characteristics and to have normal sperm development and production. There are some synthetic available forms of androgens, which basically they just change, they're trying to modify the structure so as, you know, to prolong the half-life of the hormone and to give us products which have more androgenic or anabolic effects depending on the condition that we want to use the androgens for. Okay, so androgens, to produce their effects, they bind to specific nuclear receptor in their target cells to be effective and to produce their effects. Testosterone, you know, it's like in it is the active substance or the active hormone, the muscle and in the liver, while in other tissues it has to be metabolized to its derivative, such as dihydrotestosterone. And these structures include the prostate, seminal vesicles, epididymis, skin. So for these organs, the testosterone has to be converted by 5-alpha reductase to dihydrotestosterone to be able to bind to the to its nuclear receptor to produce its effect. Okay. In terms of infertility, whether it is primary infertility or primary hypogonadism, as the one caused by this testicular dysfunction, or whether it's secondary hypogonadism due to failure of the hypothalamus or pituitary. Both these scenarios, the androgens are the ones that are used to treat infertility. They also can be used to treat chronic wasting associated with cancer or immunodeficiency viruses. Sometimes some of the preparations, for example, like denazole, can be used in the treatment of endometriosis, okay, which is ectopic growth of the endometrium, and also for fibrocystic breast disease. It's a weak androgen, a synthetic one, and can be used in these cases to prevent the hormonal, it's hormonal dependent, so to suppress the estrogen production and suppress the signs and symptoms caused by these diseases eventually. Okay. It's important to know that testosterone by itself is ineffective if it's given orally because of the inactivation by first pass hepatic metabolism. So that's why they try to change the structure of testosterone to make it to make it easily, or to make it available for oral administration. So the preparations that are available and can be given orally include fluoxymisterone and oxandrolone. Okay, so both of them are orally active testosterone derivatives, and they have longer half-life than the naturally occurring androgen, so they work for longer than the naturally occurring androgen. Like side effects of androgens in the male, actually they can cause priapism, they can cause impotence, decreased spermatogenesis, gynecomastia, and they can stimulate the growth of the prostate. So, but this is if given in excess, like not the like normal physiological at the normal physiological levels. That's just if it's given a really large amount. Okay, now we come to the gonadotropins, the follicular-stimulating hormone, the luteinizing hormone, and the human chorionic gonadotropin. So we know that the gonadotropins are produced by the pituitary cells, and they are very important in the reproductive process. So for the males, for example, FSH is the primary regulator of spermatogenesis. I suppose you've taken this in physiology, so you already know how FSH and LH regulate spermatogenesis and testosterone synthesis. So while FSH is responsible for the regulation of spermatogenesis, the LH is the main stimulant for testosterone production. Also, FSH helps in maintaining large amount of or high local androgen concentration by stimulating the androgen binding proteins in sertoli cells, so they maintain local high level of local androgen around the developing sperm. So that's why they maintain, or they are important for the regulation of spermatogenesis, and they also stimulate the conversion of testosterone to estrogen. FSH, LH, HCG, human chorionic gonadotropins, they are available in different preparations, and they are used to stimulate to treat infertility in males by stimulating spermatogenesis, and in females by inducing ovulation. So probably next, for the treatment of female infertility, we're not going to repeat this section again, because they're basically the same preparation almost. Okay, so minotropins, this is the first available gonadotropin, which is basically extracted from the urine of postmenopausal women. So it contains both substances which has both FSH and LH like properties, and it is called sometimes as human menopausal gonadotropins. Human menopausal gonadotropins, minotropins with FSH and LH properties. For the FSH, the follicle stimulating hormone, we have three forms of purified one that are available. These include the urofolitropin, okay, which is extracted from the urine of postmenopausal women, and we have two recombinant forms. So one which is extracted from the urine of postmenopausal women, and two recombinant forms which are folitropin alpha and folitropin beta. They have same chemical structure as that of the human FSH. The recombinant form has a shorter half-life than the one purified from human urine, but it is as effective or maybe more efficient than the one which is extracted from the urine of postmenopausal women. So it is basically has a shorter half-life, but has the same efficacy as the one extracted from the human one, which is extracted from the human urine. Okay. For the luteinizing hormone, the recombinant form which is available currently is called lutropin alpha, and for the human chorionic gonadotropin, as probably you know, that this hormone is produced by the placenta, okay, and it's excreted in the urine of a pregnant woman, where it can be extracted and purified. I don't think I'm going to ask you about the structure of this hormone, but basically it's just a glycoprotein, and that's a description of how it is formed of 92 amino acids and of 92 amino acids alpha chain and 145 amino acids beta chain, and there is a recombinant form of this hormone as well, which is called choriogonadotropin alpha. The gonadotropins and the human chorionic gonadotropin, they all exert their effect through G-coupled G-protein coupled receptors. In terms of the side effects, these are some of the side effects that are reported with the use of these hormones, and this include headache, depression, edema, precocious puberty sometimes, and very rarely antibodies, autoantibodies production against SCG. And if gynecomastia also can happen, but this is related to the level of testosterone that is produced in response to treatment. Again, as we said previously, the gynecomastia depends on how much testosterone is injected or produced in response to treatment with gonadotropins. Yeah, that's it. This is the end of the lecture. This is simple. I try to simplify the lecture as much as I can, actually. You need to know that there are some available preparations of gonadotropins and testosterone. Basically, also there are some modifications that can be done for its structure to be able to be administered orally. Most of the preparations are available as IM injection. Transdermal injection is transdermal patches, available as well. And always important to tell the patient with these preparations they need to be careful when they handle these products. يعني مثل مرات الميل مثلا بالترانسديرمال باتشز الميل يطلب من زوجته انه هي تخلي لي اياه او كذا، فلازم تكون لابسه gloves لانه هذا كل شيء يصير بيهن absorption through the skin and their hormones, so they just بالنسبة للفيميل إذا تاخذ androgens يعني تستوستيرون يخرب لنا الأول بالتالي قلت يقولون فيعني they really need to be extremely careful when they handle these preparations. Thank you so much for your listening, and if you have any question, just post it on the if you like to have a Telegram group or something, I'm ready to answer any questions that you have. Thank you so much and good luck.